Good afternoon. My name is Marissa Weiss, and I'm from the Lymphology Marketing team here at JOBST. Thank you so much for joining us today for our webinar series. Our topic is compression bandaging for lymphedema. We hope you find it interesting and informative. As this is a recorded session, we will not be taking questions at the end. However, you can direct them to me and I will get them answered. I will now pass it over to our host, Brittany Matozzo, from Penn Therapy and Fitness in Philadelphia.
Good afternoon, everybody. I want to welcome you all to this webinar. We're going to talk a little bit about compression bandaging and review the components of the active phase of care. So to review our objectives, we're going to look at the goals of compression, talk about indications for treatment, review compression supplies and the actual manual part of bandaging. The active phase of care will be discussed, and then we'll look into options for reducing limb volume without necessarily taking your patient through bandaging. So the goals of compression bandaging. As long as you understand the goals of compression bandaging, you will be able to bandage any shape limb, any size limb that walks into your clinic. Everything in the body flows off of a pressure gradient. So there's no reason why the lymphatic system has to be any different. In a normal cone-shaped limb, the ankle is going to have more pressure exerted on it compared to the thigh, because areas of a small radius are going to have more pressure exerted than an area of a large radius. Following 4 principles, this will help us make the law of Laplace in our limb. So the 4 principles are applying the bandages using varying widths. So the smaller the foot, for example, the foot is small, it's going to have a smaller size bandage than the thigh, which is larger. So use varying size bandages. You bandage distal to proximal. So you always start at the toes, you work your way up to the thigh. You have equal spacing between your bandages, so there should always be a 50% overlap from the layer prior. And then you'll have consistent tension. So it's not like you're trying to strangulate the limb and apply as much pressure as you possibly can. You're just taking some of the slack out of the bandage and then laying it nicely against the limb. So the idea is that we are generating a very high working pressure and a very low resting pressure. So when the patient is moving, the bandage that we made is going to be more of like a soft cast. The muscle is going to push into the bandage, which is then going to push into the lymphatic space and help promote reabsorption. When the patient is resting, so they're sitting, they're relaxed, the bandage is going to stay that same shape. So it's not going to constantly want to tighten. Now, this is sometimes what we see with an elastic bandage or an ACE wrap. It always wants to tighten because there's so much elastic. The lymphedema bandage should be very, very comfortable. So like I had mentioned earlier, if you have a cone-shaped limb, that gradient is going to be automatic. If you have a patient with a columnar shape, it's our job to build that gradient through the use of all of our lymphedema supplies, and then applying more bandages distally will increase some of that compression distally and again, exhibit the law of Laplace. So benefits of compression, again, like I had just stated, muscle pumping is promoting flow and reabsorption back into the venous system. So we want to take advantage of muscle pumping. It's going to reduce the production of new lymph fluid. We're going to soften fibrotic tissues. So the foams within the bandage are going to provide a micro massage against the tissues and help them soften. Now, a lot of times if you have a very fibrotic limb, you are not going to see a huge reduction in the volume until that tissue softens. So you have to give that type of limb some time. And then we're going to normalize limb shape. So we're going to help provide a more normalized shape, try to get as close to that cone shape as possible. Now, it's our job, especially since we're therapists, we need to encourage exercise while the patient's wearing compression. And this should automatically be included in our plans of care. So I always like to ask my patients what kind of exercise they like to do. If you force somebody to do a certain type of exercise, it's likely that over time they're not going to want to do it. They're going to become non-compliant because it's just something that doesn't interest them. So you really need to get patients involved in this area. So when do we bandage and when do we not bandage? Indications for treatment. We know our lymphedema, phlebolymphedema, venous insufficiency, status post any trauma or surgical related edema, and then lipedema with obesity-induced lymphedema. They're all a go. They should all be medically cleared to be treated. I'm going to jump over to contraindications for a moment. We know that if we have advanced arterial disease, there's already an issue with blood getting to the tissues. So if we go and apply a bandage, we go and apply compression, are we going to be limiting blood flow to the area even more? Now, this can cause significant pain and can cause a lot of other medical issues. Advanced renal disease and active congestive heart failure. Your kidneys and your heart are part of major circulation. So if they are already not working properly, or one of them is not working properly, and we're taking a patient through the decongestion phase, are they going to be able to withstand extra fluid that is getting pushed to them? Acute DVT, which is a deep vein thrombosis or a blood clot, if that's not medically managed, there's a chance that we're messing with the pressures within the limb that we can mobilize it. And then acute infection. And sometimes this is inevitable. Sometimes you'll be taking a patient through a course of care and you'll unbandage the limb one day and you'll notice the signs of infection, redness, warmth. Patient may be complaining of flu-like symptoms. This is something that you want to call the referring physician about, explain what the patient's presenting with, figure out if the patient needs to go to the emergency room or go back to the physician's office. And then before they leave my office, I always like to outline the actual area that is red with a marker so that by the time the patient gets to a physician, they can see if it's spread beyond that border. Now, this is a topic for a different day, but please keep in mind there is a difference between edema and lymphedema. Lymphedema will respond to compression within 2 to 3 sessions. If a patient's presenting and after a few days of bandaging, you're noticing no change in their presentation, it's likely not lymphedema. There's something underlying that needs to be addressed. So therapy should be discontinued and the patient should be referred back to their medical physician. Now, I'm going to jump back to precautions because this is a very gray area. Mild arterial disease, follow the guidelines. Know when you can compress lightly and know when you cannot. Mild renal disease or history of congestive heart failure. You need to make sure that those organs can withstand extra fluid being pushed to them through decongestion. So whether that's referring back to the physician that sent the patient to you or it's referring to the specialist, patient needs to be cleared. We have hypertension. We have limb paralysis. So again, we're not getting that muscle pump. There might be sensation issues. Same thing with diabetes. If there's sensation issues, you really want to be smart about skin checks and assessing that skin every time you take the bandage off. And then malignancy. Malignancy, if a tumor is obstructing flow, there's really nothing we can do. Our goal is to make that patient comfortable. And again, with any of these issues, you have to get the medical team involved and make sure that they really understand what complete decongestive therapy is and what it entails. So just some guidelines for bandaging with a patient that has one of these precautions. Increase the padding where the law of Laplace is pertinent. Decrease your bandaging tension, so just lightly lay the bandage on the limb, because again, we're worried about building layers. Start bandaging on a Monday, so then at least you can monitor response throughout the week, and then progress bandage slowly. So you're monitoring, again, for symptoms. So if you have a patient that has a full leg, toes to groin, that is swollen, start from toes to the knee, and maybe apply 2 bandages on the calf rather than 3, so that you're just introducing them slowly and seeing how they're responding. So layers of a bandage. It's just showing us an upper arm bandage. So we have our stockinette, which is meant to wick moisture and junk away from the skin. We have our finger and our toe wraps. So we never leave our fingers or our toes out. swelling is smart and will go to the area of least resistance. So we always have to include them in our compression bandaging so we don't push fluid to those areas. Cotton padding, I love. Think about building up the joints so that you're supporting the joints because you still want movement and you want to encourage movement. You don't want it to be uncomfortable. Foam, we have open cell, closed cell, sheets, or rolls. The open cell is going to come in 1 inch, ½ inch, or ¼ inch. Now, 1 inch foam should only be used to help build out the limb shape. So it's meant to improve contour. So if you have to cut a piece out here or there to help support a lobule or bridge a gap somewhere, that's all 1 inch should be used. You shouldn't be using this as your main anterior and posterior limb foams. And then regarding ¼ inch and ½ inch, you have to use professional judgment. How are you going to best make the lavaloplast pertinent? And what does that patient's limb need? What stage of lymphedema are they in? And just because you start with one type of foam doesn't mean that you can't change it down the road. You're going to reassess that limb regularly. Medium stretch or gauze, that's going to hold all of the foams in place. Just kind of make your structure so that you're ready to put your short stretch bandages on. So short stretch is 100% cotton. It's only going to stretch 50% in length. Compared to an ACE-wrap, like I had mentioned earlier, that stretches up to 300% its length because there's so much elastic in it. So again, we reassess our limbs every time that we take a bandage off, and it allows us to figure out what we're going to do that day, how we're going to structure that bandage, what kind of tools in our toolbox are we going to use so that we're accommodating for these changes. So looking at some JOBST products, we have Tricofix, which is our stockinette. There's also a cotton stockinette that you can use as an alternative. Sometimes patients will report some redness or irritation after bandaging for a few days. Sometimes just switching to a cotton stockinette can alleviate that discomfort. Elastomule, so this is our fingers and our toe wrap. Artiflex, which is our cotton padding. Comprofoam is a rolled foam. So this is really nice if you want to roll it up the arm, just say from the wrist going up to the axilla. You can get some overlap. Very nice for the calf as well for like a venous insufficiency type of patient. Isoband, holding your foams in place. It's a medium stretch bandage. And then of course we have our Comforlon. So when I start bandaging, I like to lay everything out on a tray. And I'm missing here my masking tape, my marker, and my scissors. But I like to lay everything out so that as soon as I sit, I'm ready to bandage. I don't have to get up and down. All my supplies are literally at my fingertips. So there are my bandaging supplies. We can't forget about the foams. So we need our foams ready to be used as well. Now there's two different options for foams here. The foam on the left, that picture is just a forearm outline and then an upper arm outline. So that's just two pieces. You take the foam and you wrap it around the limb and you leave a space for the antecubital fossa. On the other side, it's showing that you can use 4 pieces of foam, 2 for the forearm, 2 for the upper arm. It's really just your preference and what you feel most comfortable with. We can't forget about our dorsal pad. So our hand, of course, needs to have foam on it as well. The little carrots in the top right-hand corner, I really like to help improve anatomical architecture between the metacarpal bones. And then the donuts on the bottom right-hand corner, they're really nice around bony prominences. And sometimes I'll even cut one in more of a shape of an oval and place it over the antecubital fossa. Again, if a patient's complaining of some irritation and you tried to add more Artiflex, but it's still uncomfortable, this sometimes does the trick. So now I'm taking all these foams from the School of Lymphology in my binder when I took the course. So don't be hesitant to go back to your original binder and pull out this information, because you should always start a bandage, a very textbook-based bandage, see how the patient responds, and then add different techniques, add different advanced techniques as you're progressing them through therapy, and you feel like you need to help progress them a little bit faster, a little bit differently. So here are our leg outlines. We have an anterior and posterior calf. We have an anterior and posterior thigh. You can see on the calf there is a relief that was cut down the middle for the tibial shaft, just to give some pressure relief over that bony prominence. And then on the left-hand side, there is a dorsal pad, there are ankle wheels, and there is a little kidney-shaped foam that you can put posterior to the malleoli just to improve the anatomical architecture at the retromalleolar spaces. Now, all these dotted lines that you see on all of these foams, that means that the foams are beveled. So you want to bevel the edges so you're cutting them a little bit on an angle so they contour nicely when you're applying your bandage. So next, I am going to take you through a video of me bandaging an arm. So you can see I have my tray. I have everything set out, ready to go. I included my marker, my tape, and my scissors. I assume that my patient has washed or showered earlier that morning, or she washed her arm when she got to the clinic. It's dried, and I start by applying my lotion, knowing that skincare is part of one of the pillars of CDT. Now you can bandage a patient in a chair, on a mat, wherever is accessible to you and wherever the patient is most comfortable. So I use a pillow for support. And I start with my finger wraps. So I anchor around the wrist, spiral up the thumb, and then I spiral down. And it doesn't matter whatever finger you want to start with, as long as everything's getting covered, it doesn't matter. And I like to pinch in between the fingers. So I pinch the finger as I move the bandage so that I'm holding it in place. And then by the time I spiral back down, I'm making an X back at the knuckle. Her hand is also spread, so her fingers are fully abducted. And the bandage got away from me, but I'm still able to apply it with accurate tension. So I'm not going to undo my whole bandage. I'm just going to go with it and let it lead the way. So now I targeted all 5 fingers. I'm going to come up and just lay it down nicely just to tie that end back so it doesn't get in the way. But when she makes a fist, I want to see if there's any other gaps. And I noticed a few gaps. So now I'm taking another piece of bandage and just going through, applying what they call the breast cancer ribbon to the base of each finger and just improving my coverage. So she makes a fist. We have great coverage. I don't need any more, so I'm going to cut it and then tuck it in the top. Now everybody has a different preference using their stockinette, so I'm just showing you what I do on a regular basis with my stockinette. There's a little hole cut in it already for the thumb. And now I'm going to start with my cotton padding or my Artiflex. So I make a little hole. Again, I hook it at the thumb. And I lay my padding down. Now, there's no reason to have to apply this with any sort of tension. This is just a nice cotton weaved product, so you're just laying it. It's just for comfort and to hold your foams in place. So I'm going to show you, there's my dorsal foam, and I'm going to use my cotton to hold the foam. Now again, I keep stating this, but pick the foam that your patient's limb needs. For this purpose, for the purpose of this webinar, I have used 1/2 inch foam throughout the entire limb. And go back and forth a little bit at the elbow, the same way I did at the wrist. Again, we want them moving, we want them comfortable. And then I always pull the stockinette back far enough just to see where the dorsum pad is. Sometimes as you're applying your Artiflex, that dorsal pad can move forward, so you might need to readjust it. All right, now this is the second video, so this is picking up where we left off. I pulled that stockinette back down because I realized my dorsal pad was in a good spot. And now I'm starting with the forearm pad. So I place that on the forearm. I bend the elbow to make sure that I'm not impeding elbow flexion. And then I start securing my foams with isoband. And I have everything labeled. So I know exactly where it should go, or if I'm out, my colleague will know where it goes if they're covering for me. And then there's good coverage at the olecranon. So you bring that posterior forearm foam up enough to cover the olecranon. Again, I have it labeled. There's a little divot where the foam is going to go kind of in between the arm and the axilla, just so it's not digging into the axilla. And then there should be overlap between the posterior upper arm foam and posterior lower forearm foam at the elbow. So then as I spiral down, I'm just kind of laying, smoothing out as I go. I'm not applying my isoband with compression. And then there's gaps between the foams, about 1 inch, so I'm allowing for decongestion. And then I leave a relief again at the elbow so that the patient can move. Now, it's good to reassess comfort in between each layer that you don. And this will become more important when you start to apply your bandages, because nothing's worse than applying the entire bandage and then your patient complaining of discomfort. So, in between each layer, assess the gradient, ask the patient if they're comfortable before applying the next layer. So now this is just a standard hand bandage. If you recall from your courses, you do the 3 X's, you cover the X in between each layer, and then you spiral up the arm, and you move the bandage out of the way around the thumb so you're not causing, again, any discomfort there. And I use my other thumb just to kind of help smooth out the foams and suck out some of the air to give a little bit of a nicer shape. Now, again, we have to remember the law of Laplace, so that's going to come into consideration when you're determining if you need a palmar foam. So sometimes people like to cut like a half a moon that will get wedged in the palm around the thumb to help improve the radius. So that's always an option too. Now with the rest of my bandage, I'm going to spiral up and help mold out that wrist. Now I like to bring my stockinette up over the dorsal bandages, over the hand bandages. It keeps them nice and contained. The Artiflex doesn't slide out. and it's just past the wrist, so then I could catch this in my next bandage. So now I just have the patient's arm resting on my belly so that all the muscles are activated, increase the circumference of the actual limb a little bit, again, for a comfort standpoint. And then I start bandaging. And I always anchor with the end of my bandage up, just so I make sure, I always say I'm catching the edge so that the edge doesn't get loose and cause the bandage to unspiral. So now I'm just spiraling up. I'm pointing where the elbow is, so this is where I want to make my release. So I come up to the upper arm, I anchor in the upper arm, I bring my X coming down, again, pressure release at the elbow, and then I can continue to spiral up from there. And I start up a little bit higher. Again, I catch my edge. And now I'm just doing a spiral all the way up, 50% overlap. You can see I kind of take the tension out of the bandage before I lay it. And I could use my opposite arm, my opposite hand to help smooth out the bandage so there's no wrinkles. And once you get to the top, you just lay the bandage down. Just lay it coming back down so you're not confusing the gradient. And then I tuck my stockinette in between the layers so it doesn't slide down. Now I'm choosing to apply this bandage going in the opposite direction, so I'm handing it to my other hand. Patients will sometimes report shoulder discomfort if you always wrap the bandage going in the same direction. So sometimes I like to switch it up session to session, or sometimes I'll just put one bandage going one direction, one bandage going another direction, so they don't experience that discomfort in their shoulder. And if you look, you can sometimes see the outline of the layer of the bandage prior, and that will tell you where to put your bandage for that layer. Always trying to make sure that you're ending your bandage more anteriorly, not posteriorly or medially. If your arm's rubbing against your body, there's a chance that the teat may become loose, the bandage could unspiral. And I'm checking my gradients. Remember, you want to do this in between every single layer. You want them to move in between every single layer so that you're catching any issues prior to progressing your bandage. So that's what the bandage looks like when we're all done. So you can see it's a little bumpy at the joints, but the more that you're working with your foam, the more you're breaking in your supplies, that contour will smooth, the foam will smooth out nicely to where you want it to be. Now, it's really important that you have good techniques when you're bandaging. If you're applying these bandages and your technique is poor, it can lead to a lot of significant effects for your patient. So just to name a few, there can be disruption of arterial blood flow. So we're limiting blood flow getting to the area if we're causing a tourniquet effect. Hypertension leading to venous disease. So we're causing issues again with the pressures within the limb. Entrapment of lymphatic fluid. So if you look at this picture, you could see there's gaps where the bandage has been laid. It's likely that fluid is being trapped in the areas that are not compressed. You can have nerve issues. So if the bandage is really, really tight in certain areas, which you can tell right proximal to his ankles, the bandage looks like it was pulled a little tighter. That could be causing a pressure to the nerve, which can lead against sensation issues or even cause some sort of shearing forces and disrupt the integrity of the skin, leading to a wound. Now, we've all had patients that have walked into our clinic presenting with this. And I do get some heart palpitations because I tried to explain to the patient that this form of compression can actually cause more harm than do good, and really explain to them the role of our treatment and why our treatment is recommended rather than this. So over time of this being uncomfortable, the compliance to using this treatment strategy is going to decrease. Now, one more thing I'm sure you're noticing on this picture is that the bandage is secured with safety pins and not with tape. Now, anytime I get a bandage and I see a little clip in the bandage, I automatically throw them out. Because to me, that's just a risk for a wound puncture, a risk for infection, and a risk I don't want to have to put my patient at. So as much as we're teaching the patient about what lymphedema therapy is and about what their role in care is and what their role in this process is going to be, we need to learn about them. So it's very important that we are honest and upfront with our patients when developing their plans of care. They need to be included in the plan and in setting their goals. So one thing I always like to ask my patients before I start treatment with them is if they've ever had treatment in the past. So if they have had treatment, I want them to paint me a picture of that experience. I want to know as much about that experience as possible, because the more informed that you are as their treating therapist, the better you're going to be able to shape their program for success. So just to recap, some things that we want to know. Have they had treatment in the past? If so, learn as much about that experience as you can possibly learn. Pick out any red flags. Is there anything sticking out to you that may hinder successful outcomes during the course of care you're about to start with them? Do they have any supplies at home? Is there anything that they have that can be reused during this course of care? And in their perspective, what worked well and what didn't? So how our team works when it comes to the active phase of care, if we're going to take a patient through compression bandaging, we recommend 3 to 5 times a week for at least 6 weeks. It's likely that they are going to need to be seen a lot longer depending on the severity of the limb, depending on the stage of the lymphedema, if wounds are present, but at least around 6 weeks. The patient needs to remain in compression until the next visit. So if you see them on Monday, it is expected that they are in their compression until they walk back in the door on Wednesday. Now, I will tell patients if they are experiencing pain, numbness, tingling, burning, they can take the topmost layer of their bandage off. If the symptoms resolved, beautiful. Stay like that till the next time they come in. If the symptoms are persisting, take off the next layer and keep doing this until their symptoms resolved. Because I'd rather them be comfortable and have only one layer of compression bandaging donned than be uncomfortable and struggling to get into the next appointment. They need to be independent with their responsibilities. So they need to come into therapy early. They need to doff their bandages by themselves. So with this, we're really trying to encourage, improving range of motion, especially if it's a lower extremity. We want them to be able to reach their feet, reach their toes, take off their bandages. It's only going to prepare them when they have to put their garments or their devices on in the maintenance phase. We want them to be independent with their ADL. So after they take off their bandages, we want them to wash their limb, lotion their limb, get ready for their session. And then we try to always make sure patients have one set of bandages to wash and one set of bandages to wear. So that set of bandages that they took off, they need to take home and wash them, dry them, and roll them so that by the time they come into therapy the next session, they have those clean bandages, they're laid out, they're ready for use. They need to obtain proper footwear. So sometimes we'll recommend a cast shoe just because it could accommodate the foams and the bandages for the widened foot. Or they can go to a store and buy a cheap pair of sneakers that are maybe too 2.5 sizes bigger than what they normally wear, again, to accommodate for the girth of their bandage. You don't want a patient to come in ready to start treatment and then they have no shoes to wear, nothing to wear on their feet when they're ready to leave. They need to arrange transportation to and from clinic. So not everybody drives, and not everybody has a caregiver that's able to take them back and forth to therapy. So here in the city, in this urban setting, we have public transportation that can take patients back and forth to therapy, but this needs to be set up at least 10 days in advance. So there's a lot of planning on the patient's part regarding their rides. And then funding. I have this highlighted and bolded because unfortunately, funding rules our plan of care. Patients need funding for all the supplies for treatment and then all the supplies that are needed for the maintenance phase of care. Sometimes people's insurances will not cover the supplies needed or will not cover the devices, and unfortunately that helps, again, determine where we're going with treatment. So if we have bandaging supplies and we start a patient through a course of care, but we don't have anything or don't have the funds to get patients the appropriate garments or devices to put in after, we're going to be like a hamster in a wheel. We worked really, really, really hard, but there is no end goal in sight. So this really needs to be determined. Now, one thing I like to do, we have a residency program here. When I spend time with our residents, I ask them, just look at the limb. If you're looking at the limb and not taking into consideration everything else, the social history, the medical conditions, the funding issues, just look at the limb. What type of garment would you put the patient in, daytime, nighttime? Then I say to them, all right, we're going to be realistic. What would you put your patient in, or what are you going to put your patient in, knowing everything that you know about them? After doing your complete physical therapy and lymphedema evaluation, what are you going to put your patient in now? And a lot of times, unfortunately, those two things are different. From a resident, from a mentoring standpoint, it's a really good eye-opener, and it's a really good way to challenge yourself regarding different products that are available and long-term management. And then to the right, again, is just a picture of CDT. So if we have a patient that is not appropriate for bandaging, because not everybody that we're going to evaluate is going to be appropriate, what are the possibilities? What are the other issues that might be affecting this? And then what are the other options for treatment? So they can have a functional mobility limitation where they're not going to be able to have both lower extremities bandaged at the same time. Funding limitations, lack of caregiver support, so they don't have an extra assistant to be able to help them take the bandages off or clean them. Wound drainage, somebody with copious amounts of drainage might not be able to, or might need to change their bandages daily, but they might not have the transportation to get back and forth to therapy daily, limited by other issues, or they just can't attend therapy as frequently. We are not, I think, as therapists and as a group, I don't think we look to bandaging alternative devices as another option. And these are the Pharos trim to fit. This is an example of a Pharos trim to fit leg piece. This is an example of the foot piece. And this is an example of the upper extremity device. We can use bandaging alternative devices to help us decongest the limb and then help them smoothly transition into the maintenance phase of care. So just to tell you a little bit more about the Pharos Strong Trim to Fit, this device can be used and throughout a course of active decongestion, and it's trimmed as the patient's limb reduces. So it can be worn again in the active phase and then in the maintenance phase, and it's a very smooth transition. So you're trimming to the point of stability. So once that limb volume is stable, you're then stopping trimming there and then allowing this patient to use this product ongoing. It's a really nice visual feedback for the patient because they're watching their success. Every time they come into therapy, they're seeing that the device needs to be trimmed. You know, they're doing their part, their limb is reducing, and it's continuing to keep compliance where it needs to be. So this device in itself has 50% overlap of the bands, and it mimics bandaging, allowing for a consistent gradient compression. There's non-elastic layers. It contours to the limb, the strong material, which I really enjoy, does contour really nicely to the limb, and it attaches simply via Velcro. So these devices you can machine wash cold, or you can tumble dry no heat. And sometimes I tell my patients, just hand wash them, lay them flat, roll them in a towel to suck up all the extra water, and then lay them flat to dry out of direct sunlight or heat. And the garments also come with a liner, so you have that protection between the skin and the device. So benefits of this option, it allows the patient to take their garments off daily. So if they have to change wound dressings, perform skin hygiene, they have that ability to do so. We're maximizing funds. If a patient only has a small amount of money, we have to really think, how are we going to help them throughout the whole course of care? So we can use this again with decongestion and then with maintenance. You can use with foams. So maybe you don't trim it as much as the patient's limb says you should, but if you apply foams underneath, you're getting the benefit of the foam, you're helping improve contour, you're helping improve softening of the tissues, you're getting kind of the best of both. Upper extremity and lower extremity options, so it's not just available for the legs, it's also available for arms. It's reducing the frequency of the session. So instead of telling your patient you need to come in 3 to 4 times a week, maybe they come in once a week. And at that point, you're reassessing their limb, you're reassessing your plan. You're looking at the foams. Do they need to be trimmed? Do the devices need to be trimmed? Giving you a way to kind of stay on top of it and keep the patient engaged. So these devices can be used, especially the leg pieces, with the Pharos hybrid liner. I have a picture of that coming up, but the Pharos hybrid liner is really nice because it's acting again as your barrier between your skin and your device. You never want to put these devices directly on skin. You want to have some sort of protection, but it provides foot compression. So the patient will have compression throughout the dorsum and the ankle of the foot, and then where the compression ends on the liner is where you start the bandaging alternative device. And then this is allowing the patient to wear sneakers or regular shoes. Now, if they wear sneakers, it's really nice because when you tie your sneaker, you're going to get even extra dorsal foot compression, so it'll be a nice gradient up the leg. It's promoting independence. So you're really working on gaining independence and having the patient build confidence in self-management. Because after all, they need to learn how to do this long term. We can't go home with our patients. We have to give them the tools for their toolbox and know when to use what and then when to call us. It allows patients to shower. I don't know if any of you have ever told your patients, you have to kind of bird bath in between your treatments and you get a look, a blank stare. It's just giving patients an option to be able to take the devices off every day and get in the shower and wash. And then it can improve functional mobility, especially if you're telling patients that they can't wear sneakers, that they have to wear cast shoes. Just footwear in itself can have an impact. So again, good preparation for the maintenance phase. Now, I've had some patients that have been able to afford or have had insurance coverage for devices they have not had funding and they just refuse to learn how to self-bandage. They find a way to self-pay because they want a quick and easy way to manage the devices independently. So ideally, we recommend our patient follows up every 6 months for reassessment, sooner if you feel like it's more appropriate. So this is a patient that was seen by a colleague of mine in our clinic. She was put into Pharos hybrid liner. So there's a Pharos hybrid liner with a Pharos basic. And you can see that there's dorsal foot compression from the base of the toes up. And where the compression ends, the device begins. And she's wearing this with a sneaker. So there's nice coverage, improving compression. Now this woman, to give you a little background, she's morbidly obese, history of cardiac and kidney problems, which again were medically cleared prior to initiating treatment. She had very poor skin. Her help at home was there, but it was very inconsistent, very limited because her family worked. So in using the strategy for only 1 month, she reported improvement in her skin, in her sleeping, and in the reduction of volume. She noticed that her limb contoured much nicer. She had an ankle again. And now she's independent with management and will continue to be independent and follow up as recommended by the lymphedema therapist. And this is a picture of both legs together. You can see with the shoe donned and with the shoe doffed. So, in conclusion, you need to know the goals of compression bandaging. Again, you'll be able to bandage any patient that walks through your door. Be creative and think outside the box. Every time you see a limb, you need to reassess it and figure out what's going to be the best strategy or the best bandage that you're going to apply that day. And overall, encouraging independence and promoting success. Now, you really need to make sure your patient understands how and when they need to follow up. A lymphedema evaluation or reevaluation is just as important as a follow-up with any other specialist. And we need to really stress this to our patients. Because sometimes people will walk in the door and be like, well, I didn't know I had to follow up. You want to stress that from the beginning. Lymphedema is a diagnosis that requires compliance and consistent monitoring. Patients also need to learn how their limb responds to compression. So I tell all of my patients, it is better to stay ahead of the ball than letting the ball run you over. So encourage independence, but provide reassurance that you, as their lymphedema therapist, is always going to be there for them and always going to be in their corner. So that is the end of the webinar. I appreciate all of you taking the time out of your day to view this. Again, any questions, please email your contacts at BSN and they can direct them to me. And I hope you have a great afternoon.